part 3 of the autonomic nervous system med table, I will cover cholinergic agents. So cholinergic, the name choline is coming from acetylcholine, as I mentioned before, right? So if a patient is going to be taking more acetylcholine, what do you think the effects would be? Do you think there'll be more parasympathetic or sympathetic response? So if you know it's parasympathetic response, you're right. You could know that there are two receptors. Those are the nicotinic muscarinic receptors. I am not expecting you to know which drug acts on which receptor, but do know there are two types of receptors, the nicotinic and the muscarinic receptors. So if you think of parasympathetic response in acetylcholine, now think and tell me, why would you give this to someone? Do you think you would give someone with a sympathetic or a parasympathetic response? Or maybe to only pick some of the issues that the patient might have, right? Would you think that this patient can have a slow GI motility if you give this drug? So do you think a person with slow GI motility might need, cholinergic drug, right? And it could also be given when patients have urinary retention. And then if people have increased intraocular pressure, it could decrease intraocular pressure. So cholinergic drugs are given mostly to patients with Alzheimer's disease or when they have urinary retention, and things like that. So mechanism of action, it mimics acetylcholine. So let me go back. So indications when you want to give this when you want to slow down GI motility, right? And when a patient has urinary retention, when the patient has intraocular pressure. So I hope that is clear. So when there's increased acetylcholine receptor size, what happens is it inhibits acetylcholinesterase, so less ACH is broken down now. So it's more available. The less it's broken down, more available to the body to work. I really don't want you to remember each of these, but just generally that's how it works. Okay. Interaction, again, anytime you give these medications, you have to be careful not to give it with antihistamines because they can also dry a person up really a lot. Okay. As far as side effects, if you remember acetylcholine, its ability to slow down, it can cause dizziness, it could cause increased secretions. Because what happens is it's not actually helping to the lungs to open up, but then what happens is it increases secretions to help in resting, right? And then if you think of GI, it could cause some nausea, diarrhea, because the body is thinking, oh, I'm at rest, so I'm going to secrete more GI secretions. That can cause a lot of GI increased motility. See the problem there? And then the sphincter could be more lax. So if you're trying to treat somebody with parasympathetic, all the parasympathetic aspects might increase. And then because they're resting, you're thinking, oh my God, the heart rate might go even more lower if you're going to give them drugs. So can you see why a patient with already low heart rate should not be receiving these cholinergic drugs, because it can further slow them down? And also, how about when patient has low blood pressure or when they're already vasodilated, their blood pressure is low, right? And also when people have decreased intraocular pressure, we should be really, really cautious with patients with glaucoma. And then with the skin too, it can cause increased sweating because when you give excess of these, that can happen, right? So toxic effect, there's something called cholinergic crisis. When patients are placed on any of these drugs on the drug names that are listed here, for example, Aricept or donepezil or memantine, Namenda, these two are given for Alzheimer's. I want you to remember these two drugs, the donepezil and the memantine, can cause many of these side effects. So hence, especially in older people, these drugs have to be slowly increased, and slow doses are better than larger doses. Another drug that I want you to remember is bethanacol, uricoline. It has the term choline, meaning it's a cholinergic, right? So when patients have urinary retention, they could be given this to prevent, urinary problems. As far as nursing implications, one has to assess for allergies, GI, GU obstructions, in asthma, COPD, especially because of the effect on the lungs. And then if somebody's on uricoline or bethanacol, you have to be watching if they are urinating after giving this drug. Also, not to stop abruptly. Careful when when the patient is using it with other drugs. I think if you put all the three parts together and review it a few times, this ANS Drugs whole class will make much more sense to you. Thank you.